expressing my gratitude for people attending, my enthusiasm for the day. As you know, this lectureship was named in honor of Walter Miller, who we are honored to have here in person today. And I was reflecting that actually it's been now 2 decades exactly that I've known Walt Miller. That's a pretty scary thought of myself to think that it's been that many years, but has really been impactful for me throughout my career, dating back to when I was a resident on the other side of the country, designing some very unusual path for my own training, and his willingness to be excited about thinking outside the box really was a wonderful introduction, and has really impacted me in a number of ways. And many of us, as you probably know, Walt Miller is really a seminal player in the field of steroid biology, contributed to the discovery of multiple different diseases that we now recognize and are able to treat better because of his work, and really able to transcend the insights from the basic science laboratory into the clinic, and make an impact for our patients. And I think one other point that was probably the inspiration for me, at least part of the inspiration for having this talk, was this concept, sometimes gone unsaid, but always felt, that if we don't defend the physician scientists and make it clear our impact and our importance, to translate the basic science discoveries, the clinical research discoveries to the patients, and what the physician scientist has, the role that they have, and the impact that they have, then we really are going to miss out, and we're going to become a dying breed. And I think that this lectureship is meant to honor those contributions and celebrate many achievements across the spectrum that have represented impact for our patients that couldn't have been possible without the physician scientist. And today's speaker, Rich Auchus, really represents that quintessentially, really taking work both from the laboratory all the way into the clinic, running across the full gamut, and really making enormous contributions across the field. Many of you have read the extensive awards he's won from the Endocrine Society, Pediatric Endocrine Society, and others. And I think that that for me, maybe even more important than that, for selecting Rich for this, what we hope is a prestigious award for you, is really the recognition also that endocrinology is not this ancient old field where there's nothing new to discover. People think about endocrinology, and it's really quite extensive history and contributions over many decades, maybe even centuries, we could say. And so the question sometimes comes up, what else could there possibly be to discover in endocrinology anymore? And then we have people like Rich Auchus that are showing us, hey, there's a whole hormone that you don't even know existed yesterday that I need to tell you about. And so I think that really quiets down the questions about whether it's exciting to still be in endocrinology. And then on a personal note, I was reflecting whether I can consider myself at my age a grandson from Walt. Rich also spent some time working with Walt, as I did. I'm probably too old to be considered a grandson, so maybe a younger brother. But Rich discovered and made a lot of impact in his early days in Walt Miller's lab himself. And so there's a nice connection down the line that we hope to continue for our young up-and-coming investigators as well. And I understand Felix Conti is also listening in, so perhaps we could be the grandchildren of these generations and generations that are passing the torch of important physician scientist contributions. And so with that, I want to thank Rich for coming and spending the day with us. We have this plaque to honor him, and we look forward to his lecture today. Thank you, Rich.
All right. Well, thank you, Brian, for that very kind introduction. It is a great honor and a pleasure to be back in San Francisco. This area did not exist when I was here in the late 90s, and it's amazing how much the development has been. But it's also true that the UCSF spirit of discovery and advance is still here. So I have to take care of two quick things. First is I have to give you my disclosures. And then the second is on behalf of all of us in the Midwest, to all of you on the West Coast, I want to welcome you to the Big Ten. And I want to remind you that in this conference, we do something called defense, and defense wins championships. All right. So yeah, back in the day, this was the Miller Lab in 1999. This was my send-off party. You can see me in the white T-shirt over on the right. We were kind of a wild and crazy group, as you can tell, but we made a lot of important advances. And when I left, it was a sad time. I got my 49ers jacket, which I still wear. But I told the group that our best work is yet to come. And that actually turned out to be true, fortunately for myself, for Walt, and for many of the other people there. And I want to emphasize to the trainees in the crowd that the best work in endocrinology is still yet to come. And I think what Walt has always done as a mentor has been to allow us to experience that oceanic feeling of making a discovery and then seeing it change the way that medicine is practiced. And for that, I am eternally grateful to Walt. And of course, here's Walt doing one of the things that he does best, which is identify, open, and pour certain products of the California agriculture system. Okay, now I'm an adult endocrinologist, and why am I talking about a pediatric disease? Well, did you know that the first patient described with classic 21-hydroxylase deficiency was actually an adult? And it was this poor gentleman, Giuseppe Marzo, who died of a diarrheal illness in the mid-1800s. And the anatomist, Luigi Di Creccio, who dissected his body, noticed that although externally he was a male and he lived his life as a male, identified as a male gender, he had a uterus and fallopian tubes and two large masses on top of his kidneys. And Di Creccio kind of figured it out that there was some association. But back then, we didn't know what a steroid was. We didn't know what an enzyme was. We didn't know what a receptor was. So fast forward to the current day, and now we know that his condition was caused by 21-hydroxylase deficiency. So the block in that enzyme, which is P450 21A2 on this slide, is on the pathway to cortisol and aldosterone. And so with all forms of CAH, you have the underfill, what you're not making, and then you have the overflow to what you make instead. So putting the dam in the river at those 2 points, the only pathways left are to androgens. So there is always androgen excess and then variable glucocorticoid and mineralocorticoid depending on the severity of the block. But there's a third thing that happens in all forms of CAH, which is the misdirection. So for example, you might think that this, my pointer, no, pointer's not working, that the enzyme P450-11B1, the last step in cortisol synthesis, the 11-hydroxylase, is sitting around on vacation because there's no substrate coming through the block. But what it does instead is it reaches back and metabolizes 17-hydroxyprogesterone. And it makes something called 21-deoxycortisol, which you may have never measured, but it is a more specific biomarker of 21-hydroxylase deficiency than 17-OHP, because normal people make 17-OHP. Normal people do not make 21-deoxycortisol. And 17-OHP also comes from the gonads. So these 11-hydroxylated steroids are unique to the adrenal cortex, and I will return to that later. So I'm going to break my talk into 3 parts. I'm going to talk about the current state of the science, and I'm going to focus on the young adult, the patient that has recently been transitioned out of pediatrics. Then I'm going to talk about some new biomarkers and new steroids and what their implications are. And then I'm going to finish with new treatments. So the genetics of 21-hydroxylase deficiency are somewhat special in that it is the CYP21A2 gene, the dark orange gene, is located in a duplicated locus on chromosome 6. And the light orange CYP21A1P pseudogene is where most of these defects arise. And most of them are from a process called gene conversion, which is one of the products of Walt's lab. And then the other about 20% are due to deletions. And then there are a few true mutations. But that's why the mutations in 21 hydroxylase deficiency are the same all over the world, because they're actually derived from the pseudogene. And there are 10 different places where the pseudogene differs from the coding gene. Now, when you get true deletions, you can get crossovers in the orange genes, which gives you a chimera between the pseudogene and the coding gene. Or you can get a crossover in the blue genes pointing in the other direction, which takes out the entire 21 hydroxylase gene, but also takes out a part of that dark blue gene, which is the tenascin X gene. And that gives you a syndrome called CAHX, because tenascin X is an extracellular matrix protein, and these patients have a kind of Ehlers-Danlos syndromes. So I have a number of patients who can put their ankles behind their necks, and sometimes I come into the room and they're sitting with their legs crossed in the guru stance, but they can also bend their knees backwards. And then, as Walt showed with Jim Bristow, if they have homozygous deletions, they can have cardiac valve defects and have serious problems with that. So that's the genetics. Now, what about the treatment? Well, that goes back to Lawson-Wilkins in the 1950s. Shortly after cortisone was first synthesized, Wilkins figured out that the problem was a disinhibition of ACTH. And because of the enzyme block, instead of making cortisol or corticosterone, that androgens were being produced. He had the order of the pathway not quite right, but in the untreated state, the ACTH was making androgens that were suppressing the gonadal axis. So if you treated with cortisone, you could restore the negative feedback and allow the ovary to function in the women. And Wilkins' hypothesis was indeed correct, and that's how we've been managing people. But I want to point out that we've been managing people this way for almost 70 years now, and we haven't really made much more progress. And that's what I'll talk about at the end. So the pediatric endocrinologists know that the goals are to prevent adrenal crisis, and for this we use hydrocortisone. Now, we try to keep the dose less than 17 milligrams per meter squared per day in divided doses. But I will also point out that the cortisol production rate is about 8 milligrams per meter squared per day. So even on the best of circumstances, we are overtreating patients by a factor of 2 from birth. Then we maintain volume status with fludrocortisone and salt. We try to minimize the androgen excess, again, using the same treatments. So again, we haven't gotten very far past what Wilkins showed in the late 1950s. Now, in adults, we still have to replace their glucocorticoid and their mineralocorticoid as clinically indicated. But now I have to treat this patient for 60 years. And if I'm going to use 17 milligrams per meter squared per day, there's going to be consequences. So I don't control them as tightly as they need to be controlled in pediatrics to optimize their adult height. Once their gonadal axis is open, I have a little leeway that I can allow a little bit of androgen production from the adrenal, but not too much. We monitor for testicular tumors, as I'll mention. We counsel them about genetics and fertility, and especially in the women, behavioral health counseling. And then at the end, I'll talk about experimental therapies under approved clinical trials. So let's talk about the men and the women separately. So the hypothalamic pituitary adrenal axis is trying to make cortisol, and in the presence of the block, it can only make androgens. Now, there's a parallel axis in men, which is the hypothalamic pituitary gonadal axis, and it doesn't know where the androgens are coming from. So in a poorly controlled man with 21 hydroxylase deficiency, the gonadal axis is going to be suppressed, just as in a steroid abuser who's taking exogenous androgens. And this is one major cause of infertility in the men, because you need intratesticular testosterone production to promote spermatogenesis. The other problem they have is these testicular adrenal rest tumors, we're actually now learning that this probably starts in early adolescence, maybe even before puberty. Because if you do screening with ultrasounds, you can detect these in at least half of men and boys with classic 21 hydroxylase deficiency. So I've shown you the ultrasound appearance of a normal testis on the left, which has a nice homogeneous sandy appearance. And then in the center, you see two small hypoechoic adrenal rest tumors. And then on the right, this heterogeneous mass is an entire testis that's been replaced with an advanced adrenal rest tumor. Now, high-dose glucocorticoids will often shrink the rest tumors, but they have a variable effect on testosterone and sperm production. And of course, you can't do this forever. You basically have to keep the ACTH below 10 for the entire day. So that's usually twice a day dexamethasone. Now, testis-sparing surgery, as Dr. Baskin knows, often improves the mass effect, but it rarely recovers testicular function. So it's kind of when you're throwing in the towel and that you don't want to treat these people with high-dose glucocorticoids anymore. And again, these people have had a suppressed axis, and many of the men that I've inherited have never gone through puberty. And I have to treat them for a couple of years to get their gonadal axis to wake up after they've been suppressed by the adrenal-derived androgens. So the presence of TARTs and an FSH greater than 35 is a poor prognosis for fertility. So my target in the young men is have a normal LH and an androstenedione to testosterone ratio of less than 0.5. So if the men are making testosterone from their adrenals, their androstenedione will be higher than their testosterone because the adrenal does not have a good enzyme to make that conversion. If they're making the testosterone from their testes, their gonadotropins will be normal and their testosterone will be higher than their androstenedione. So that's currently how I manage them. So when I asked the women, the fellows, why did the women with CAH have infertility, they usually say high androgens. And that's partially true, but actually the major reason is because of high progesterone. So one step upstream of 17-hydroxyprogesterone is progesterone. And when the adrenals are poorly controlled, it's like being on a progestin-only birth control pill. Right? And so the endometrial lining never develops. And even if they ovulate, they can't get pregnant because there's no lining to implant into. Yes, they also have the problems with vaginal inadequacy and so on. But this issue of progesterone has come to the fore in recent years. But actually, it was discovered by Bob Rosenfield many years ago when he showed that the key to restoring menses was not the androgens, but controlling the progesterone. And in this case, it was done with dexamethasone. But you can see this woman is on 0.75 milligrams of dexamethasone a day. I can't do that for 60 years. So even though there's proof of concept, we have to have a better way to do this. So very few women historically have attempted pregnancy, but that is changing now. The recent data from Sweden would suggest that 2/3 of women with classic CAH are trying to have children. And I now have 4 women with classic 21 hydroxylase deficiency who are pregnant. 2 of them, it's their second pregnancy. So this is becoming the norm rather than the exception, in part because of neonatal screening, that we identify children early, we treat them up front, and we maintain them in control throughout childhood and adolescence. And again, the key is to suppress the morning progesterone in the follicular phase to less than about 0.6 nanograms per mil. And if you do that, the pregnancy rate is normal. So I've had women come to me where their former endocrinologist has told them that they can never have children because of their condition. And that is just blatantly not true. And that's not the way it's going to be in the future. So you should discuss genotyping the partner, because I know that they're going to contribute a classic CAH allele to their child. The question is, what is their partner going to give them? And the carrier frequency in the general population is about 1%. So there's about a 1% risk of having a baby with classic CAH. So if they're interested. Now, during pregnancy, the androgens and the 17-OHP are going to get scary high. And this was actually nicely shown by Joan Lowe and Natalie Spitzgabel when they were fellows here at UCSF in a nice collaboration that involved Blake Terrell and Paul Fitzgerald, who's in the audience, as well as Selena Kaplan, Mel Grumbach, and Felix. So shout out to Felix Conti, who's watching on Zoom. And they showed that it really doesn't matter. It really doesn't matter because the placenta metabolizes the androgens. So the baby is only virilized if the baby has CAH. And so my pregnant women, the OB is always calling me, you need to titrate their medicine. There need to. So I measure like electrolytes and renin. I get something, but I actually don't worry about it. Once they got pregnant, that's the hard part. Once they're pregnant is the easy part. Now, there's a literature about doing adrenalectomy in people in poor control. Should you do a unilateral or bilateral adrenalectomy and tell people that we will permanently get rid of the problem? Well, that's not true. And this was nicely shown by Debbie Merck at NIH. This is a woman who had a bilateral adrenalectomy, and 3 years later, her androgen excess came back. And what she had is adrenal rest tumors in her uterine ligaments. And so, yes, women also can get adrenal rest tumors. They're just not in the same location, and they're not easily palpated because their ovaries are in their abdomen. The other tumors that are classic in CAH patients are bilateral adrenal myelolipomas, and nobody really knows why these forms, but they can get enormous. This one was 18 centimeters. The largest I've seen is 30 centimeters. So the problem is that once these forms, unlike the TARTs, improving the control does not help. They don't respond to glucocorticoids, and eventually they need to be surgically removed. I'm just going to make a couple words about non-classic 21-hydroxylase deficiency. The children present with premature development of body hair and odor, rapid growth, voice and behavioral changes. And then the adolescent girls and young women that we see present with facial hair, acne, irregular periods, and allegedly infertility. But whenever you read a study about this disease, you should realize that 90% of the women are never diagnosed. The genetic prevalence in the population is 1 in 200 to 1 in 300. It's probably the most common genetic disease in human beings. But we only diagnose about 10% of the women and less than 0.1% of the men. So we actually don't know the natural history of this disease because those people are never identified. And the people who are identified are the ones who are screened because of things like infertility. But what I can tell you is that less than 15% present for infertility. The majority of them get pregnant in a year with or without treatment, but they have a high risk of miscarriage. And in retrospective studies, at least 2 or 3 very good retrospective series, it seems to be lower in people treated with hydrocortisone. So if somebody comes to me and they're trying to start a family, I do recommend that they take hydrocortisone prior to conception and throughout the pregnancy, and they can stop it afterwards. There's no data that the men have any problems with either TARTs or infertility, so they often stop treatment after puberty. Now, this is a situation where I try to genotype people because it turns out that 10% that present to medical attention, most of them are compound heterozygotes. They have one classic and one non-classic allele. So they're a little more severe than the homozygous non-classics, and that's why they present to medical attention. So just like we have step therapy in diabetes, I have step therapy in CAH. If someone comes to me taking hydrocortisone 3 times a day and they're comfortable doing that, I leave them on it. I really prefer to treat them with hydrocortisone if I can. If that replaces their adrenal function well, but does not control their androgen excess, it's usually that early morning rise in ACTH. And so just like controlling the fasting glucose with a bedtime dose of a long-acting insulin, I have to give them a bedtime dose of a long-acting glucocorticoid. And my favorite is liquid prednisolone. It usually only takes about 1 milligram, and I can give any dose I want because it's a liquid. But you can also use methylprednisolone or the liquid dexamethasone at very small doses. If that's too complicated, then they can go on prednisolone or methylprednisolone twice a day. And I don't do reverse circadian delivery, I do a replacement dose in the morning and then the minimum dose at bedtime to control the androgen excess or the progesterone excess if I'm trying to get a woman pregnant. Dexamethasone I reserve for TARDs and special situations like that. So how much dexamethasone does it take? Well, Lou Blevins did that experiment. It takes about 0.4 milligrams a day to control most people. Now, not everybody, some people less, some people more, but on average about 0.4 milligram a day. But again, doing this for 60 years is a recipe for disaster because even 0.4 milligrams a day using an equivalence of about 80 milligrams of hydrocortisone. That's about 32 milligrams a day of hydrocortisone. And this is a study from the French group, which showed that bone density declines linearly with your chronic average glucocorticoid dose. And 32 is even off the scale for this. So I'm not going to want my patient to take 0.4 milligrams for the rest of their life. Okay, so now I'm going to shift gears and talk about some new steroids. So I'm going to introduce that with my colleague Nemo and ask you, what does he have in common with this baby girl with classic 21 hydroxylase deficiency? And the answer is that fish make 11 keto testosterone. Now, if any of you were a marine biology major, you would know that the fish androgen is 11 keto testosterone, not testosterone. So these are sticklebacks, which is some laboratory fish species. And you can see the territorial males, the breeding males, their main androgen is 11-KT, not testosterone, because the fish gonad has 11-hydroxylase in it. And it turns out that testosterone is just as good a substrate as cortisol, as 11-deoxycortisol for the 11-hydroxylase enzyme. And the same 11-beta-HSD that oxidizes cortisol to cortisone can convert that to 11-keto-testosterone, which is a bona fide androgen. It has a potency about the same as testosterone for the human androgen receptor. So in classic 21-hydroxylase deficiency, where you have this piling up of 17-hydroxyprogesterone, some of it is getting hydroxylated to 21-deoxycortisol. Some of it is forcing its way through to androstenedione. And when ACTH is high and inducing all those other enzymes, that androstenedione is going to get 11-hydroxylated and in peripheral tissues converted to 11-keto-testosterone. So how do we look at this? We use mass spectrometry. So my lab has set up tandem mass spectrometry assays for multiple steroids. So a tandem mass spectrometer works like this. You ionize the steroids, you pick an ion, you fragment it in a second cell, and then you pick a fragment to measure. And upstream of that, we do a liquid-liquid extraction. We run it down in HPLC to separate the different steroids, and then we measure them one by one as they come on. So we put these 11-oxyandrogens, as we call them, on our panel. And this is kind of the profile you get. So again, measure about 24 steroids in one run. And it turns out that 11-hydroxyandrostenedione, which is 11-OHA here, in a series of patients, these are on treatment, this is not the worst case scenario, is about twice as high as androstenedione. And 11-keto-testosterone is about twice as high as testosterone. So for 60 years, we've been actually measuring the wrong steroids in these patients because their dominant androgens are these 11-oxygenated adrenal specific androgens. Now, in women with CAH, the 11-keto-testosterone correlates linearly with testosterone. When they're in good control, both are low. When they're in poor control, both are high. But notice that 11-keto-T is always much higher than testosterone in these patients. In the men, it correlates inversely because the man on the lower right who's in good control is making then testosterone from his testes and not making keto T, where the man on the top there, all that testosterone is coming from his adrenals because his 11-KT is through the roof. So that's how we sort of sort things out now. It's also elevated in non-classic 21-hydroxylase deficiency. So 11-hydroxyandrostenedione can be used to make a diagnosis of non-classic 21-hydroxylase deficiency without an ACTH stimulation test, because it's about 2.5 times higher than the normal population in these women. Well, but if I might digress, what about normal children? Well, we have something that pediatric endocrinologists have been interested in for a long time called adrenarche. And adrenarche is the appearance of axillary and pubic hair around age 8. And it seems to correlate with the generation of DHEA sulfate from the adrenal. So DHEAS has been used as a biomarker of adrenarche. But DHEAS is not an androgen, and it doesn't get metabolized very well to active androgens, except in a few tissues that have the steroid sulfatase. So with Josephine Kasavubu and Perry White, we took a bunch of girls with premature adrenarche and age-matched girls. And the girls with premature adrenarche, their testosterone was really about the same as the age-matched girls. But what was different, besides their DHEAS, was their 11-keto testosterone. It was about twice as high, and it was 4 times higher than their testosterone. So 11-keto testosterone is probably the active androgen that is responsible for the physical changes of adrenarche, not that testosterone or DHEAS. Well, I'm an adult endocrinologist. If we look at the other end of the spectrum, we all know that androgens decline with age. So this is pre and postmenopausal women. Androstenedione goes down, testosterone goes down, DHEAS goes down, everything goes down. But 11-oxyandrogens do not go down with age. In fact, if anything, they go up slightly. So 11-oxyandrogens are the major androgen in most women, in prepubertal children. There's only us adult men who have more testosterone, their 11-keto testosterone. So this is that unmeasured androgen that seems to be accounting for some of those phenomena that we couldn't account for with testosterone or dihydrotestosterone. All right, so the last part of the talk, I'm going to talk about new treatments. So you can dress up hydrocortisone in a variety of ways. You can block the androgen receptor. You can destroy the adrenal glands. But what I'm going to focus mostly on is a P450-17A1 inhibitor, abiraterone acetate, and the CRH receptor antagonist, NBI 77860, crinecerfont and tildacerfont. So hydrocortisone, Debbie Merck's group, again, delivering it through an infusion pump. Peter Hindmarsh did that. You get somebody who had type 1 diabetes, who got a kidney pancreas transplant, put their pump up on eBay, and you buy their pump, and then you put hydrocortisone in it, and you can deliver it programmable. And yes, you can knock down the ACTH, the androstenedione, the progesterone, the 17-OHP. That's all fine and dandy, but impractical for someone who can take pills instead. But what that did show is proof of concept. It showed that if you can deliver hydrocortisone at 3 o'clock in the morning, you can control the ACTH better. So how are we going to do that? With the modified release hydrocortisone tablet. So now Diurnal has developed, it's called FMODY, EFMODY in the European Union, and it's now Chronocort in the United States. It is a delayed release hydrocortisone. So it has an enteric coating on granules in a capsule that then allows a delay and an absorption in the small bowel. And so there's about a 4-hour delay before the hydrocortisone starts to be absorbed, and a peak about 6 hours, which is about when the morning ACTH rise is occurring. And so you can see in that very difficult to control window between 6 a.m. and 10 a.m. that the modified release hydrocortisone, the MR hydrocortisone versus standard glucocorticoid, controls that morning rise of 17-OHP and androstenedione better. But 30 milligrams a day on average. So still a lot of hydrocortisone. Now, I will say that in the extension phase study, the investigators were allowed to then further titrate as clinically indicated. And over a year or two, they were able to drop the dose to on average 20 milligrams a day and still maintain reasonably good control, letting this 17-OHP drift up a little bit as clinically indicated. And this is an important theme, is that once you get people in control and you get some atrophy of the adrenal glands, they are easier to control later on. So that bodes well for us developing other therapies for this disease. All right, so if the idea was that what we're doing is taking glucocorticoids to suppress the HPA axis, why not just block androgen synthesis? And we have a really good drug to do that now. It's called abiraterone acetate, or abiraterone. It's FDA approved for the treatment of prostate cancer, which is an androgen-dependent cancer. It's about 1 nanomolar affinity, pretty much an irreversible inhibitor of the P450-17A1 enzyme that I studied in Walt's lab and my lab continues to work on, the only pathway to all androgens. So if you block this enzyme and lower the hydrocortisone dose, the idea is that we add abiraterone, we remove the pathway to testosterone, and we control people on a lower dose of glucocorticoids. So we took 6 adult women, we lowered their hydrocortisone dose to 20 milligrams a day. They had to have an androstenedione 1.5 times the upper limit of normal, and we gave them 6 days of abiraterone at a dose 1/4 to 1/10 the level that's given in prostate cancer patients. And after 6 days, we were able to nicely suppress androstenedione well into the normal range. And what you notice is that 2 days later, the androstenedione is still down. And that's, again, because it's an irreversible inhibitor of the enzyme, and you have to make new enzyme. So this is actually, and we met the primary endpoint at 250 milligrams a day. We saw parallel reductions in testosterone and urine androgens, and we showed proof of concept that this could be used. So now there is a pediatric study that Perry White is the PI that's NIH funded. It's had a lot of trouble getting going because of COVID and various other supply chain problems, but we're still doing this work in pre-pubertal children in whom we don't want them to make any androgens. You might want to know, what does abiraterone do to 11-oxyandrogens? So we did that experiment. We were able to get some leftover samples from the study, and we mass spec profiled them. And at 100 or 250 milligrams a day, 11-hydroxyandrostenedione at the top and 11-ketotestosterone at the bottom came down nicely and into the normal range. And in fact, in prostate cancer patients, so on the left, the dotted line is the upper limit of normal. On the right, the dotted line is the limit of detection. So in castration-resistant prostate cancer, the 11-ketotestosterone is suppressed to undetectable levels. This is actually probably the reason that it works in prostate cancer. It's not because of the little further lowering of testosterone. It's because we've eliminated the unmeasured androgen, the 11-ketotestosterone, from the adrenals. All right, then to finish up, what other strategies? So instead of flogging the pituitary and the hypothalamus with glucocorticoids, can we shut off ACTH production some other way? Well, ACTH is driven by CRF from the hypothalamus. And years ago, when Wiley Vale cloned the CRF receptors, he found that the knockout mouse for the type 1 receptor was kind of a chill mouse, a happy-go-lucky mouse, a really anxiety-resistant mouse. So they developed, several large drug companies developed CRF antagonist programs to treat depression. And of course, they didn't want to use the dose high enough to cause adrenal insufficiency. And the drugs were very safe, but they didn't work. They didn't work any better than SSRIs. So they were put back on the shelves for a couple decades until we decided to repurpose them for this condition. So our first study was done with a drug called NBI 77860, where we did a single dose fixed sequence study in 8 adult women. And what we did since it was a single dose study, we wanted to measure the proximal biomarkers, so ACTH and 17-OHP. And we brought them into the clinical research unit. This was a very difficult study to do. We kept them overnight. We measured steroids through the night, and then we brought them back 3 weeks later, and we gave them a 300 milligram dose of the drug, 1 dose at bedtime with some food. And then we measured the steroids through the night. Then we brought them back 3 weeks later, gave them a higher dose, and did the same thing. So the concept, and this is just conceptually, the arrow shows that we delayed the morning dose of glucocorticoid until 2 o'clock in the afternoon, because we wanted to really see what the drug did in the absence of any glucocorticoids. So they took it at bedtime, it would peak during the night, and it would be present in the circulation during that time when ACTH and 17-OHP normally rise. And what we found is that the drug delayed and attenuated the rise at ACTH and 17-OHP at both doses in this cohort, especially during that 6 to 10 a.m. window. That is the most difficult time to achieve control. So that showed proof of concept. This drug was not taken forward into phase 2 trials, but what was taken forward was crinecerfont and tildacerfont. So crinecerfont has finished 14-day trials in both adults and children. In the adult trial, in 4 different cohorts, from 50 milligrams once at bedtime to 100 milligrams twice a day. Tildacerfont has gone through 14-day treatment studies at several doses and a 3-month treatment study at 400 milligrams at bedtime. And the phase 2 and 3 trials in these drugs are now fully enrolled. So I'm going to show you the data from the phase 2 trials with crinecerfont first. So these are the study designs. Again, very arduous, very difficult study to do, overnight studies in the clinical research unit before and 14 days after taking the drug. There was the cohort 1 was 50 milligrams at bedtime, cohort 2, 100 milligrams at bedtime, cohort 3, 100 milligrams with the evening meal, and cohort 4, 100 milligrams twice a day with the morning and evening meal, which is now being carried forward into the phase 3 trial. So what did we find? We saw greater than 50% median reductions in ACTH and 17-OHP in all the cohorts, and that's shown here. So these are quite dramatic reductions. If I was to do that with glucocorticoids, I would have to give them about 15 extra milligrams of hydrocortisone a day. And then we saw clinically meaningful and dose-dependent reductions in androstenedione, up to 2/3 of a reduction at the highest dose of 100 milligrams twice a day. And so numerically, that means ACTH from a few hundred down to about 100, 17-OHP from tens of thousands to a few thousands, and androstenedione, where 200 is about the upper limit of the normal range. Most of the people are in the normal range after being poorly controlled for many months at the end of the 14-day treatment study. The pediatric study was just published. Ron Neufeld and his colleagues in UCSD, Patricia Fechner in Seattle, and others. So this is showing you that key morning window. Now in the children, we only delayed the glucocorticoid dose to 10 o'clock in the morning. But in these adolescents, you can see beautiful reductions in 17-OHP and androstenedione, very little rise during that difficult to control morning window. Now, you might say, why haven't I talked about testosterone in these studies? Well, testosterone is tricky, right? Because in the women, you want the testosterone to go down. But in the men, you don't want the testosterone to go down. You just want them to make it from their testes. So how do you know that? You look at the androstenedione testosterone ratio. So in the women, in the young ladies in this pediatric study of adolescents, the testosterone went down about 75%. But in the men, it didn't change. But their androstenedione testosterone ratio went way down. So I can only infer that that meant we improved testicular function in these young men. Okay, so tildacerfont 14-day treatment studies. These are waterfall plots of individual patients. You see that many patients have good reductions in androstenedione, 17-OHP, and ACTH. And that in the 3-month study, the patients with poor disease control, ACTH came down right away. 17-OHP bounced around, but eventually came down, and androstenedione took the longest to come down. So again, after 2 weeks, you get some control, but after 3 months, you get better control as you maintain the pressure to get some adrenal atrophy. So where are we at now in early 2024? Well, the crinecerfont 3003 adult phase 3 trial has met the primary endpoint. At 24 weeks, we were able to reduce glucocorticoid in many more patients in the treatment group than in the placebo group, and yet maintain androstenedione control. And it has been given FDA breakthrough designation. The crinecerfont 2006 pediatric study, which I know is also being done here by Maya Ludish and her colleagues, also met the primary endpoint. Greater reduction in androstenedione at week 4. And then they also showed glucocorticoid reduction with maintenance of androstenedione controls. Tildacerfont, 2 phase 2b studies are now fully enrolled, and a pediatric phase 2 study has been started. So now on the horizon, CRN 04894 is an MC2R antagonist, which is the ACTH receptor, melanocortin type 2 receptor. There is a phase 2 trial that we have just started at Michigan. We're starting to enroll our first patients. There is a therapeutic antibody to ACTH that the phase 1 trial has been started in Europe, and there's a gene therapy trial that BridgeBio has started, and they just had a press release last week that they've seen cortisol productions in some participants as they've pushed the dose of the virus. So there's a lot of different ways that we can approach this. And what's gratifying to me is that over the years, we've used the science that we've learned to come up with the first new treatments for this disease in 60 years. That's long, long overdue, because we know the outcomes of these people after they've been treated with these high doses of glucocorticoids for 60 years, and it's not good. So as Chicken Little said in the movie 10 years ago, today is a new day. And I think that very soon we will have better ways of simplifying management, making less arduous for the children and their parents, and then allow these people to go into adulthood and live happy and productive lives. Because as my theme has been, is that normal is normal. And we can't stop in trying to develop new approaches until we have these people normal. And we've made one step further to that, thanks to the work of all the people throughout the globe. So I am grateful to the people in my lab and Bill Rainey's lab, Adina Turku in particular, who's done the work on the 11-oxyandrogens, all our clinical study coordinators. Iyad Al-Safadi was our main guy on the 3003 trial. We've had funding from our various agencies for the lab work, our sponsors for the clinical trials. And I thank you for your attention. And I'm greatly honored to have been chosen to give this Walter Miller lecture today.
Well, that was really terrific and inspiring. Thank you so much. I think we do have time for some questions. People on Zoom, if you want to send them into the chat, I believe we'll do our best to fetch them and announce them and respond to them. I did want to also just take a moment to acknowledge our funders, Corcept and ArborMed, that trusted us with unrestricted funds to support this lectureship. When they were not involved in the selection of the speaker, but I think that they probably enjoyed this talk, and we're not obviously involved in the content at all, but we are very grateful for their funding. And I think we can take some questions if you guys have some for us, for Rich.
Rich, that was beautiful. Thank you so much. Very inspiring. Could you comment a little bit more on the approach to the gene therapy aspect?
So, okay, the gene therapy is delivered systemically. So in mice, there is a mouse model of 21-hydroxylase deficiency. Of course, it doesn't have androgen excess because mice don't express 17-hydroxylase in their adrenal, but they have adrenal insufficiency. So if you deliver the gene systemically, some of it gets into the adrenals, and it can actually restore corticosterone synthesis in the mouth. So you don't have to like give intra-adrenal injections. So that's the good news. The issue is, where else does that virus go and what does it do? So I, in particular, am concerned as if it goes to the liver and sets up shop there, what's it going to be doing to the precursors that are percolating through? So, but no, it's just given systemically. And it's an AAV5 vector that's being used for this. Yeah. Bob?
One of the biggest problems in CAH is prenatal treatment. Any role for any of these, any data thus far supporting or refuting use in prenatal treatment? Because this is a true point.
Well, I would say one of the greatest controversies in CAH. Yes. Oh, repeat the question. So the question is, one of the biggest difficulties in CAH is prenatal treatment, and are we anywhere closer to developing new treatments? I would say one of the biggest controversies in CAH is prenatal treatment. So when I have my adult women who have CAH, and I talk about this with them, their answer is like, wait a minute, you mean the worst thing that could happen to my daughter is she winds up like me? What's wrong with that? I think it's all a matter of perspective. I think actually the situation is a lot better today than it was when prenatal therapy was being develop, because we have, surgeons like Larry Baskin that can take care of these young ladies when they need it. And we know how to manage them from childhood now. So I think that's going to just disappear as a problem as time goes on. Yes, you will still have the virilization, but I think we'll be able to handle that in the future. Now, what I think you would have to do, it's conceivable to, we don't know if the hypothalamic pituitary adrenal axis is even functional at the time when sexual differentiation occurs. So it's kind of not clear to me why dexamethasone even works. But I think it's possible that direct androgen antagonists or the MC2R antagonists might be able to cross the placenta and change things. But the problem is you have to know ahead of time. And how there's some evidence you can do fetal-free DNA at 4 weeks before you need to start. But you have to know before you start treatment, you have to know they have it, right? And you're not treating people who aren't affected. But I actually think nowadays, that's like actually the lowest problem on my list. Yeah. Kevin.
Yeah, so I had two questions. One is, one's maybe a little bit off the wall. But the first is, as a translational scientist, when you have a therapy that's been around for 60 years and it works okay, but not so well, and now you have this first new therapy that's really a major advance, that then establishes a new standard of care.
Right.
How do you then sort of justify doing trials of the next generation of therapies? Do they have to go on standard of care?
I think that's right. Yes, right. So you then have to have an active comparator. You can't deny if that becomes the new standard of care, you can't deny people the standard of care. So it has to be then another quantum leap from what we've just done. And you have to have, or you have non-responders. So people who failed the CRH antagonist. Yes. So I think, the bar is going to keep getting higher. And every time you get a new treatment that is approved, then you have to do better than that. You can't just be a me too.
And the second question is kind of just a broad one, and that is that in addition to using steroids in endocrinology, we use it to treat, rheumatologic diseases, autoimmune diseases, lymphoid malignancies.
Right.
Is there anything you see coming down the road that might sort of, on the one side, decrease toxicity, and the other side, increase the specificity of activating the GR pathway?
Well, the people from Corcept might have something to say about that. So they've developed some selective GR antagonists that have tissue-specific effects. I mean, that was, the pharmaceutical industry worked for a long time trying to dissociate the anti-inflammatory effects from the other effects of glucagon, and failed. But that was because they were working off the standard steroid template. And as you then consider the universe of other scaffolds, chemical scaffolds, then you can come up with these agents. So yes, so there are such agents available now that are being trialed for that. The two other things are the 11-beta-HSD1 inhibitors. So the enzyme that recycles cortisol from cortisone is particularly highly expressed in liver and fat, which are the bad places for glucocorticoids to act. So if you block that enzyme, you can attenuate the cortisol or prednisolone effects in those tissues while maintaining it in the immune system. Okay, so there's those two things. And I think the third thing is recovery. If there's CRH antagonists, can you make a CRH agonist? And can you expedite recovery from HPA axis suppression in people who have received pharmacologic glucocorticoids? So I think there's a couple of things along those lines that are coming down that are actually here. Two of the, actually, they're all at least in preclinical development right now. Well,
two things that I guess reflect my ignorance of the work that you've done recently. One is I don't really understand what's the difference between crinecerfont and tildecerfont.
Oh, they're just two different CRH antagonists. So they're
doubles your work.
Well, yeah, but I mean, there were probably a dozen of these that made it into phase 2 trials in psychiatric disease. And it was only 2 that were picked by different companies to trial in CAH. And so there's, I mean, they're not both from the same company. That's, I think, the reason. Yeah.
And the second question is, you gave us a beautiful introduction to 11 oxoandrogens, especially 11 ketotestosterone, which is probably the principal offender in early childhood and in CAH. But you didn't show us any 11 oxoandrogen data with your CRH agonists, with your crinecerfont.
We haven't been able to do that yet. That because of the way clinical trials are done, it gets done through a CRO, a clinical research organization, and they hold all the samples. So just like the abiraterone study, I had to wait 2 years after it was done to get those samples. I hope it won't take that long, but I'm planning to get those samples after the study's over. Yeah.
Any other questions? Well, we want to reward the people that came in person and encourage the Zoom people to come next year. We're looking at try and match this. It'll be a difficult one to match, but we'll do our best. But thank you all for coming, and please enjoy the reception.
Okay.